All right, it's now my pleasure to ask our chapter founder, Dr. Roger Moczygemba, to give some opening notes to you.
Thank you, Shankar. I so much appreciate the good work of my co-founder, Shankar, and Deborah and David Doro from my clinic for showing up and working here. So you heard a little bit of my introduction. I'm not going to repeat that, but I'm so excited for this meeting to have you guys here. I want to show you what I'm very excited about. Over the last few years, we've been hammering away at developing this meeting, this community. So I'm going to have some people stand up. You don't have to be a member of our San Antonio chapter or the main FMMA group, but if you are a primary care doctor, please, in the room, please stand up. Okay, so everybody just look around, take note, thank you, have a seat. If you are a secondary care provider, like a specialist, do we have anybody like that here? Okay, there you go. Thank you for coming. Thank you for being here. So we got primary care, secondary care, tertiary care. If you're a tertiary care provider, please stand up. You guys are tertiary care, right? You have a hospital, right?
Correct. I represent a lot of tertiary care.
Okay, right. Okay. All right. Family hospital system. Okay. So primary care, tertiary, secondary care, tertiary care, and we need a few folks that know how to put it together. If you're a broker or consultant, please stand up. Awesome. Thank you for being here. So now the people that pay for all the health care, if you're an employer or a health care purchaser, please stand up. Awesome, thank you. So that's what I'm so excited about. We have the whole healthcare spectrum here, and it's transparent and it's direct care. And so purchasers of healthcare can take advantage of that. So everybody that stood up, please recognize what we're doing here and help us grow this community. And let us be, you guys didn't stand up. But
well, I said tertiary care. I mean, we're all 100% surgery. But
well, that's okay. So we have another resource. Okay, we'll hear from you guys next time, maybe. Okay. So yeah. So everybody bring your friends and let them know what we have growing here. The more we can build this community, the more value. And we want to. We want to be an example of healthcare done right, affordable access to care done right. And we even have political representation here, Jacqueline Hall from Chip Roy's Healthcare Advisory Committee. And so if we can be an example of that, then we can show other lawmakers how it's done, and policymakers. Okay, so that's why I'm excited to have everybody here. So I will turn it back over to Shankar and introduce our program.
All right. Well, we will hear next from Dr. Wes Clements. If you want to come to the lectern, he has entertained me with my requests for going live on Instagram. We did that together. When you run into him, he'll show you his clinic. It's just really amazing to know you, Dr. Clements, and I'm very happy that I got you to present tonight. So I'm going to bring your keynote up. You should have a clicker there. Yep. So let me just bring your keynote up. All right.
Okay.
So last year, I was hospitalized at the Methodist Medical Center.
I think I turned the mic off. You might want to turn that on.
Hello? Testing, testing. Testing, hello?
Turn it on again.
Testing. Great, thank you. So last year, like I said, I was hospitalized at the Methodist Medical Center. What do you think was the bill? I'll give you a hint. I was in the hospital for 28 hours for a kidney thing. Any guesses?
12,000.
12,000? 18,000? 12,000? 18,000? These are good guesses.
48,000.
48,000. We have one for 48,000. All right. Okay, all right. I'll give you a couple more hints. I was there, like I said, for 28 hours. I had about 3 bags of fluid. I saw a nephrologist, a hospitalist, got some blood work and urine tests. So I'm hearing a broad range of prices here. What's that?
Were you admitted, Dr. Clements?
I was admitted.
So through the ER?
Through the ER.
All right, 78 grand. 87.
All right. So apparently I'm talking to people who actually know the industry pretty well. So nobody's underestimating. That's good. Okay. All right. It was $22,000. All right. So that comes out to about $785 an hour. And to be honest, myself included, I was also not too surprised. I'm in the healthcare industry. I was like, not a bad deal. Not a bad deal. All right. I had never been hospitalized before in my life. So as some might say was bad luck or maybe poor judgment, I'd actually gotten rid of my health insurance a few weeks prior to that event. For the first time in my life, I went without insurance. So literally, I was hospitalized in January, and that December is when I got rid of my health insurance. I did not have health insurance. You see, for years, leading up to that event, I had learned about how backwards our healthcare system is. I had the privilege to learn about an alternative form of healthcare consumption. And it turns out that not having health insurance was one of the better financial decisions I've made. So my training is in family medicine, which means I'm truly just primary care, right? I see everything. I see everything from chronic diseases to urgent medical needs. I have a 2-month-old patient and I have a 95-year-old patient. All right, so we're truly the front line of healthcare. And because of that, we're in a unique position to really get a grasp on how our healthcare system functions. By following our patients for long periods of time, decades, or even generations, we can see the downstream consequences of health events. We see the good and the bad of the healthcare machine. So this graph right here is my optimism about our healthcare system. It was a roller coaster ride. So at the beginning here, kind of neutral. I'm in medical school and residency, deep in the books, just studying, enjoying. I was completely oblivious to the economics of my decisions and the decisions of my institution. I may have been saving lives, but I was also wrecking them. After residency, I went into private practice, and my optimism tanked. I learned 3 truths, at least my truths, about the healthcare system. Truth number 1, the healthcare system, the U.S. healthcare system is broken. Truth number 2, I don't believe it can be fixed. And truth number 3, primary care isn't dying, it's already dead. I have a suspicion that in this audience I don't have too much explaining to do about these truths, but bear with me just for a minute. Number 1 here, healthcare system is broken. So for example, try establishing with a neurologist or psychiatrist within a month here in San Antonio. There's some new neurologists in the field though, so we're glad to have them. All right, how about try to speak with your primary care doctor about more than 3 problems in one visit. Or maybe ask a local hospital how much it costs to get a CBC, a test that everybody gets in the hospital. Ask them how much it costs. They can't tell you. Well, I can, $1,900, okay, at that hospital visit. That test costs like $2, actually. Okay, some other problems with the U.S. healthcare system. How about the fact that when you lose your job in the U.S., you also lose your access to healthcare? How about some of the racial disparities and differences in outcomes in healthcare? And how about the fact that healthcare is the #1 cause of bankruptcy in the United States, and 70% of those bankruptcies occur in those with insurance? Sorry, this talk gets a little dark. I promise it gets brighter. Truth number 2, the healthcare system cannot be fixed. I heard someone say, and I think it was Allison actually, who said about a year ago at this conference that the healthcare system's not broken. It's working exactly as they designed it. It's making a few entities a lot of money. There is a lot of money. The top 5 revenue-producing companies in the United States go like this: Walmart, Amazon, Apple, CVS, and United. Well, how about maybe the government fixes it? Okay, let's all laugh together at that one. Oh. All right. Whoops, let me go back one. And lastly, primary care isn't dying, it's already dead. The main goal of of healthcare is honestly to absorb as much money from the insurance pot as possible. That's how the US healthcare system works. It's a game. You try to do that without going to jail, and you're the winner. Primary care is focused on prevention and cost-effective treatment early in disease. Translation, it's not a revenue producer. Through policies and strategies from the top, primary care is often reduced to basically a glorified referral coordinator. People don't trust the healthcare system anymore, and honestly, I don't blame them. The primary mission is not to serve them anymore, not to serve the patients. All right, now we're going up. Then I learned about free market medicine, opened a direct primary care clinic, and joined the revolution. So what is direct primary care? First of all, it's primary care, full scope primary care where we get to practice how we like. Second, it bills only the patient directly. We don't bill insurance. And lastly, the majority of revenue in a direct primary care clinic is from membership. That's an important difference. We're not fee for service, meaning we get paid to keep you healthy and not paid per disease or per health event. But why would someone pay their own hard-earned money for primary care? I mean, insurance primary care is $25 copay, sometimes even free. It's been devalued so much. Well, I actually believe that paying your primary care clinicians directly, you actually get better service and for a better price. See, DPC memberships are usually somewhere between $80 to $150 a month, some more, some less. And for that, you get a lot more. You get a full primary care experience with better service. You get often better access, same or next day availability. You get increased time with your clinician, 30, 60 minutes in a lot of clinics. You also get actual urgent care needs often. You get good preventative care, in-office testing and procedures, which if you have insurance can cost hundreds of dollars. And the visit's free, but then you need all these other tests in the office and they charge more than that. Or the visit's free and insurance care, but it's included in your membership with DPC. You also get, I think it's underrated here, you get effective chronic disease management, meaning people who can really talk to you about your ongoing conditions and really get control of them. It's great for clinicians because we can return to doing what we love, and what's best for our patients. I'm just going to provide 2 quick examples of how DPC encounter looks, direct primary care encounter. Let's look at example 1. Patient has a UTI on a Saturday. They call their this is a traditional clinic is what they're a member of. They call their traditional clinician. It's Saturday, they can't get in, no one answers the phone, or maybe someone answers the phone, but they just send them to the nearest urgent care. Several hours later and several $100s later, they get their antibiotic. It took them half a day to a whole day to get this taken care of. Or maybe, because their deductible was so high, they were scared to go to the urgent care, so they didn't go. They just chugged a bunch of cranberry juice. They developed a kidney infection and sepsis and went to the hospital and needed IV antibiotics. Let's imagine the direct primary care scenario. UTI, classic symptoms. They know their clinician knows them. They text their doc, hey, I have burning with peeing. Okay, here's an antibiotic. They send it in, and 5 minutes later, the antibiotic's ready. Example number 2, type 2 diabetes. And this is a real story. Patient has severe uncontrolled diabetes, insulin dependent, on insulin, 120 units. For those who don't know, that's a lot. And they see endocrine, nephrology, ophthalmology, all the ologies. Their healthcare, their life is really their healthcare. They're seeing all these clinicians 3 or 4 times a year. And not once was there any time to have a meaningful discussion about reversing, managing, or getting on top of this disease. That patient joined a direct primary care clinic, and 6 months later, they had lost 60 pounds and came off their insulin, which I didn't even know was possible when you're at 120 units. I suspect that patient who joined the DPC managed to have meaningful discussions about important things, resistance training, eating well, and reverse that disease. I believe they're going to get 10 more years of healthy years in their life. In the conventional insurance model of care, not only is the patient losing out, but so are the employers. Employers are facing higher and higher monthly costs for a crappier plan, honestly. The deductibles are going up, and the networks are becoming more restrictive. As a matter of fact, the situation is so bad that many employers aren't even offering health insurance plans to their employees. And if they do, maybe their employees, especially the mid and low wage earners, are not taking them up on that health insurance plan. For obvious reasons, right? Like, why would you pay hundreds of dollars a month out of your paycheck for a deductible that's so high you're going to go bankrupt before you hit it anyways? I mean, I would argue that's actually a poor financial decision to take someone up on their insurance offering. Weak benefits affect companies' talent recruitment and retention. It also affects employee morale and health. So direct primary care clinics around the US and here in San Antonio provide care to employers and employees at a discounted rate often. Employees love it because they're getting wonderful access to care and they're not paying a penny. Even better, direct primary cares can save medium and large employers tons of money. This has been done and documented. By extracting primary care and its associated costs from claims, you can reduce your healthcare spend a lot. Imagine those patient scenarios I talked about. Now you don't have the UTI going to the hospital. Now you don't have the patient with type 2 diabetes battling this disease for decades, needing to see a cardiologist and all that stuff. I bet that type 2 diabetes is going to cost probably $1 million or $2 million less over the course of their lifetime in claims. But what happens if you need something beyond primary care and you have an alternative insurance model or no insurance? Well, introducing the free market medical ecosystem. There's wonderful things like direct pay pharmacies, free market surgery centers. There's programs that assist people with getting good cash services. Imaging centers and labs, and many direct primary care clinics have accounts with these imaging centers and labs to get even further discounts for their patients. There's great therapy, psychotherapy, and physical therapy that's cash pay or discounted. And you know, I say insurance, I have to put an asterisk on this. I talk bad about insurance in general, but not all insurance is bad, okay? There are insurance agents out there and brokers and advisors who are working for the employers and not the insurance industry. And if they're here, they're the good ones. So about once a week, I hear, how is this possible? This is too good to be true. You can't treat high blood pressure and heart disease and cuts, scrapes, bumps, do laceration repairs, all for $80, $100 a month. You can't treat my hair loss all the way down to my toenail fungus for $80 to $100 a month. Well, I'll tell you, it's actually pretty easy, and it's a simple concept. There's a secret sauce here. Patient and provider incentives align. That's the key. DPC clinics are paid to keep you healthy, effectively, not paid for the disease. So now the entire system is working for the patient, not the insurance company. I could talk for an hour about how this shifts everything from how the clinic functions, from the technology in the clinic, and how it actually affects medical decision-making on behalf of the patient and beneficial to the patient. In short, we are not the same thing as your insurance-based clinic. We're not your Minute Clinic by CVS. We're not even distant cousins. We're not on the same planet. Okay, as far as I'm concerned, we're in a different industry. We're in the healthcare industry, and they're in the insurance industry. So again, the key to why DPC is so awesome is we're working for our patients, and we truly love it. Real grassroots primary care is flourishing, and it's growing fast. So in the last few years, I've realized, yes, the US healthcare system is broken. And yes, maybe healthcare can't be fixed. but we can disrupt it either to the point that it adjusts on a foundational level, or it doesn't change and we just make it obsolete. Primary care isn't dead, insurance care is dead. So what's next? If you're a DPC clinician in here, stay strong, don't get distracted. Stay true to your mission of serving the patients. We're in control right now. Let's not give that up again to healthcare, private equity, and large corporations. If you're another form of free market medicine here, and you want to help out with DPC, please approach us. Come to us with what patients care about, why your service is better, and what the costs are of your most common encounters are. Those are the two things patients care about, and therefore the two things we care about. If you're a patient or an employer, you need to be courageous. Looking outside the status quo for benefits is scary, but you can't afford not to. Learn about your option by speaking with either a DPC clinician or with a broker who you might meet tonight at the Free Market Medical Association. These are the people looking out for you. When I was discharged from the hospital, I was just packing my stuff up, getting ready to go, and a lady walks in with an iPad and is very apologetic and says, "Oh, I see you don't have insurance." And she says, do you have that information? I said, "No, I don't. I don't have insurance." She said my bill was $22,000, but they would apply a 90% discount. So my total bill was $2,200. If I had been hospitalized a week prior, I would have had to have paid my $5,000 deductible on top of the premiums that I was paying. So sometimes traditional insurance care just feels like an exclusive club where you get to pay more for things.
Dr. Clements, did they offer that discount or did you negotiate?
Straight up offered it. Didn't have to do any negotiation at all.
Yeah, goes to show.
Yeah.
Right?
All right, thank you. Next to the lectern is Dan Hobson, founder and CEO of Rise Recovery. A few of my agency clients are recovery centers, and they tell me it's impossible to make this affordable. So I'm very curious to hear what you present to us tonight, Dan.
Hi there. I always introduce myself as, "Hi, I'm Dan. I'm an alcoholic." I got sober 20 years ago, also a drug addict, so I kind of won the addict lottery. When I first got sober, it was, I guess it really got out of hand when I was injured in the military, and a pain specialist prescribed me what I believe irresponsibly a whole bunch of opioids. And then, I was having anxiety, of course, and then I started learning to play the game. Before I knew it, I had probably 5 or 10 military doctors that were prescribing me whatever the heck I wanted. It only took maybe about 3 or 4 years before things really got out of hand, and I was using between 8 and 10 grams of heroin a day. So when I got sober, I was looking for things that worked. I didn't have all the resources, didn't have any of that stuff. The military sure as heck wasn't going to help me. Back then, I was told the national statistics were between 5 and 7% on their first attempt would stay sober for good, which is not very good if you're in my position. So I knew that I was going to have to do everything that it took. So I was always looking for more resources. So that's kind of built on my recovery now, to where I'm constantly looking for better resources and things to make my recovery better. Because even though I'm 20 years sober, they always say we're always 30 inches away. And I want to help other addicts to build better tools that can help them that may be outside of the gamut that we currently have to have better success. So fast forward now, and I've been now working as a professional in the field as a drug and alcohol interventionist for about 18 years. In my personal recovery through programs like Alcoholics Anonymous, I've watched tens of thousands of people in and out of the rooms. I've watched people, go and get into a car accident, get prescribed irresponsibly again, narcotics, and then they go out and they're back out in heroin. I could probably list 5 examples of people that have died in the last week. In my professional career, I've worked with, I don't know, between 2 and say 4,000 people, probably more than that as an organization, but me personally. And I've watched in the industry, I've watched outcomes go down. There are, in the last, say, 8 to 10 years, there's more providers in the addiction space than we've ever had. Just in San Antonio or Austin, I bet you there's probably 60 or 70 treatment providers, which is pretty nuts. Now nationally, the outcomes have gone down to between 3 and 5% on an average of 6 attempts to get sober. So if you have a loved one that is struggling with addiction, national statistics say that even if they go to treatment 6 times, which would cost you approximately $1 million, they still only have a 3 to 5% chance that they're going to stay sober long term, which long term statistics average 12 to 18 months. So those aren't very good. I think that the treatment industry on how we address addiction on a behavioral side and a medical side, I think is just broken. So about, maybe I'm wrong, 5 years ago-ish, I had met Dr. Higgins, and we decided to find a solution on it. See, I had already been running treatment centers, and I've already been, working with physicians. I had put some of my own teams together. We tried some really unique things, and we had found some interesting data. And the physicians at FHS were also pretty excited about it. Decided to make it kind of a pilot project where we took on a small handful of patients and did not care about the finances. In fact, I think probably the first 4 or 5 we just scholarship and treated. And the goals were no narcotics, nothing that's habit forming, period. Get them off of the narcotics and habit forming things as comfortably as possible and have them leave hopeful. So there's no single medical intervention that's going to go and do that. So we had to kind of build this system, and it's evolved. And so today we use totally non-narcotic. So if, for example, if we're taking somebody off of, heroin, we don't use drugs like Suboxone or any kind of opioid replacement. Yet the patients are still asymptomatic. A typical opioid detox is about 7 to 10 days. Using drugs like Suboxone, we can do it in about 48 hours asymptomatically and reduce and totally eliminate all the post-acute withdrawal. On top of that, there's things that we want to do that can contribute to their long-term outcome, which is not, it goes beyond a treatment center. So if anybody that doesn't know, the traditional track is you need to get sober, you go to a detox facility, or first you go to an ER, then you go to a detox facility, then you go to a residential, PHP, IOP, and so on and so forth, all the way down to outpatient. Your first 30 days costs on average about $50,000. And I just think that, in the majority of the time, they're usually on some type of habit-forming medication that they plan to get off later on. And outcomes just go down. They're not good. So anyway, now we've kind of evolved, and we can do things like take people off of high-dose methadone, say 250 milligrams of methadone in less than a week, and with 0 narcotics asymptomatically. My reasoning for mentioning that is, I know we have an addictionologist in here, over the last 18 years, I can count, at least 10 people that were on methadone for a very long period of time. They spent a lot of money on it, and when they want to get off of it because they're not functioning properly, maybe it's causing them cravings to go and use other drugs. When people typically go off of it, they have to switch them back to opioids, then they put them on Suboxone. Every single step in that process and taper down, there's a higher prevalence of relapse. Ultimately now, with fentanyl out there, it only takes one time. So we for the long term of it, we try to avoid those things, but we also want to give an avenue for somebody to get off of those. There are currently, at least to my knowledge, there's not any other organization in the country that can achieve what we have. Same thing with alcohol. We don't use benzodiazepines or anything that's harmful. So that's the medical side of it. Then we have the aftercare medical side, where patients have medical needs while they're in recovery. Like myself, being a sober alcoholic drug addict, I'm very meticulous about who practices medicine on my behalf. So, I'm not going to allow someone to, put my well-being in harm. So, what was it, 3 years ago, roughly, I needed to have a shoulder surgery, again from injuries in the military that I've been putting off for a very long time because I didn't want to be prescribed narcotics. I didn't want narcotics during my surgery or after. So I talked to my shoulder surgeon, who's not in our organization, and he said it can't be done. If you're going to have to do it, if you have to do the surgery, you have to, you're going to have somebody watch you closely, or you're just going to be in a lot of pain. I didn't accept that, so we got a group of surgeons together and we did this kind of pilot project because some surgeons, the whole thing that started was some surgeons were saying, encouraging their patients not to take a drug called naltrexone. I don't know if anybody knows. Okay, so it's an opioid blocker, blocks cravings, it saves a lot of lives. But they were urging people not to take that because if you get in a car accident, you're not going to be able to get any pain medicine. So I kind of wanted to disprove that. So I took a bunch of naltrexone for 10 days. We had the rules were no narcotics, no, I don't want any opioids. I want to keep my pain level down. So they did a arterial line to basically monitor my blood pressure throughout the whole time. I stayed in the hospital for 2 days just for monitoring. And I wanted to air the whole thing live on Facebook. So we did it, and so I had a completely pain-free, non-narcotic surgery and totally pain-free recovery, which for somebody like me that's a drug addict, that's huge. We've now done tons of surgeries, anything from spine to not just ortho, anything. What it takes is it takes a village, right? It takes a team of physicians, a team of professionals to sit around and talk about what is legitimately best for this patient. So the medical aftercare side, and then there's the behavioral side. We have psychiatrists that actually care about the patient. We have addicts like me who are trained for peer recovery support and all those other things and achieve long-term recovery themselves to go into the room with the patient. And they're in the rooms with the patient the entire time during their stay, sharing their own stories, providing hope, and just treating people like human beings. We don't put them in gowns. We put them in these really cool t-shirts. On the back it says, "Never give up without a fight." We do a lot of social events that we fund. It's not a marketing thing. For example, we do a camping trip in San Antonio. This will be the 11th year. This year we're going to have 700 sober addicts coming, and we do meetings, we do all kinds of other things, and then we provide the addicts that are in the rooms that are visiting with the patients, we're calling them for the next 18 months to go hang out, have coffee, which is it breaks all the rules in treatment. Not only since we have sober addicts that are doing it, now the physicians are doing it, and the nurses are doing it. They develop these really personal relationships with the patients. We spend very little money on marketing, if any, and we have patients fly to us from all over the country because of our outcomes. And they range, because now we're seeing a lot more, but in the last 5 years, we've never fallen below 60%. What I think is, for me, what I think that long-term recovery looks like is not just 18 months of abstinence from all mind and mood altering substances, but I also think it means, having a strong social circle, repairing those relationships with family, having a decent job, having a credit score, and improving your relationship with all those other things that are associated with drugs and alcohol. And every patient is a little bit different, but we kind of have this toolbox of all these physicians and all these just different providers to kind of formulate and put together the best package for that patient. The best part is that it's 10% of the cost of what going to a traditional residential treatment center would be. So I think that the fact that our outcomes are going down and we have more providers or more treatment centers that are out there, I think it's a sad thing. I think fentanyl is continuing to be a big problem, and if we don't change something about it and we don't encourage other physicians to stop prescribing narcotics and learn how to talk to addicts or people that you suspect are addicts, learning what avenues to really take other than here's a number or a hotline to call it. If we can't do that, I think that we're just going to continue failing. That's all I got. I appreciate it.
Thank you. Dr. Higgins, I think it would make sense for you to go next, if you will.
My name is Dr. Henry Higgins. I'm the founder of Family Hospital Systems. We're primarily located in Austin, Texas. We're getting ready to open a facility on Bandera Road, which will be licensed as an acute general hospital. Most of my career has been spent in trauma centers. My longest stretch where I worked at the same place was in a place called Abilene, Texas. I was one of the trauma docs for about 10 years. I actually got so disgusted with the practice of medicine, especially emergency medicine, that I was about ready to throw my stethoscope in the trash. My wife didn't like Abilene. She wanted more culture. So, honey, where do you want to move? I want to move to Austin. They've got a lot of culture. So we moved to Austin, and I had no idea what I was going to do for the first time. And I've got 4 children that haven't gone through college yet. Around that time, there was opportunities to open what's called an emergency center. A lot of emergency physicians were doing that. So I took all my life savings and opened up an ER. We took an old Suzuki car dealership, and this was right after 2008 had very long-term effects on the economy. There was a Suzuki car dealership that had been closed down and empty. So I pestered the broker on that, and I took my life savings and I was able to purchase that land and building and renovate it into a licensed facility called an emergency center. Some of my friends, partners, joined me in Cedar Park, Texas, and I thought that was the last job I was ever going to have. We started practicing emergency medicine the way that we thought we should, which is a very high level of accountability for the care that we provide and the cost, and becoming very ingrained in the community that we serve. For the first time in a long time, I really enjoyed being a doctor again. I basically went into the medical field because I like to help people. I don't really care about money, I just like helping people and being able to survive. I'm sure that I share that sentiment with most of the people in this room. One of the things that was very, very frustrating to me, I was a paycheck doc. I got my paycheck every month for covering the shifts. I didn't have to worry about anything. I had no clue. My wife took care of all the health insurance for our family. I had no idea even how health insurance even worked until I owned a facility. The more and more I learned, very quickly, I became very disgusted because it's a completely messed up system. This is back in 2014 when we opened our first facility. 2015, we were already trying to sell memberships to our facility. We called it cage-free care, and we very slowly accumulated a practice where I have cage-free care patients that I take care of, that I've known for years. But what happened is by placing ourselves highly accountable for the care that we provide and the quality and the cost, we had a whole bunch of very good nurses, imaging techs, physicians that really wanted to work with us. Well, we didn't have enough space. We ended up building another facility in Round Rock. We had some folks move in from out of state to open up one in Georgetown. We opened up a number of facilities. We accidentally built, and I say accidentally because that was never the intent, a small healthcare system. And most of our facilities are what you would call neighborhood facilities. They're very small, but they're very well equipped because the physicians get to pick out what kind of equipment we get to use. And we focus basically on the people in front of us, which are our patients. And we held ourselves accountable to the costs, and et cetera. We have always bent over backwards trying to serve our community for the care that they need, especially when it comes to money. In order to open up a facility like that, you have to take insurance, but there's an awful lot of people that come to us that don't have insurance or can't afford their copays or whatever. We've always created pathways for that. We also formulated kind of a very unique, robust form of direct primary care. We worked with direct primary care physicians in the community. And a lot of this, it's like the comment earlier where if you're gonna eat an elephant, you have to take it a bite at a time. That's so true. We've learned a whole lot over the last 9 years. We've seen a lot of failure. We've tried things that didn't work, that didn't make sense. We're on the cusp of opening up a hospital in Bandera. Where we see ourselves situated is trying to help this movement take off. I don't know of many tertiary centers that are real passionate about getting unaddicted to insurance, but we are. In fact, we have a relationship with about 32 different specialty surgeons in the Austin market. We've worked with most of them to create their cash pay rate. And we go behind the scenes and, okay, how much does it cost to do a lumbar laminectomy? How much does it actually cost? What kind of profit that's reasonable do we really need to make here? And we come up with a price. So we're able to go to the patient and say, hey, it'll be X number of dollars. We've been using different platforms. MD Save, some of you may have heard of. Look it up. We're on there. Many of our students, we've got ortho and general, spine, plastics. We're about to get ear, nose, and throat. We have several different specialists that are participating with some of the platforms. It's amazing. We've been actually getting a lot of calls, but we would like to be a resource to help you find affordable health care for your patients. Yes, we take insurance, but no, we're not thrilled about it. We're very interested in the cash pay model. There's an awful lot of waste that goes on when you're trying to fight an insurance company to have them make payment. Dan Hobson, one of my partners, I've known this guy for about 5 years. Our hospital system is not owned by venture capitalists. We are basically a bootstrap company that represents a bunch of healthcare professionals that got sick of working in the big hospital system and wanted to do it a better way. We're so adamant about trying to be fair. One of the things that we're getting ready to do later this year is turn our entire company into an ESOP, an employee-owned company. We're just different. We're not motivated by money. We're motivated by quality and results. I met Dan Hobson about 5 years ago and realized I had spent 10 years of my life in the Hendrick Trauma Center. Sometimes on a monthly basis, I would see 500 people. I don't have a lot of time to treat 500 people. When somebody would come into the trauma center and they were an overdose on heroin, I felt like I couldn't help them. Oh yeah, I can give them Narcan, I can get their blood pressure up. But when they wake up and then they run out of the ER and they got brought in by cops, you end up with a wounded inner child when it comes to addicts. And nowhere is that more prevalent than in a trauma center where I came from. So that's my background. Dan Hobson comes into our office with my colleagues. We're sitting there with our jackets on, all professional. And of course, the first thing out of Dan's mouth is, I'm a former heroin addict. Great. I had already formed a wounded inner child about addicts. I had that helplessness feeling, that I didn't know what to do with those patients. I didn't have anything I could help them with. And Dan explained to me that he does an intervention, he'll spend 50 to 200 hours on a patient, a person, trying to find the exact right time when they can become intervened, when they're ready to try to do something about their problem. He has to take those patients to an emergency department somewhere to get them medically screened. You can't skip the medical stabilization, because if you do, you're going to miss things that can cause a patient to die when they're in the midst of their recovery. So we agreed to take 20 patients, and Dan also said that, yeah, we're getting really good results. You know, more than 50% of our patients recover for meaningful sobriety. What does that mean? Well, it's 2 years to life. Okay, but there's no way you're getting better than 50%, because the national average is 3 to 5%. That's what I was thinking. There's no way. So I am the CEO, but I also work, and I treat patients. And I also am certified in internal medicine. I put myself as the treating physician for the first 20 patients. So day, night, whatever, if a patient came in, I came in, sat with them, talked to them. I gotta tell you, going in the room and talking to some of the patients who've been drinking for 20 years, been through recovery 7 times, and you learn about the actual patient and some of the triggers. And I was walking out of those rooms thinking, there's no way we're gonna get this person off alcohol. It's not gonna happen, but I'm gonna play along. Well, we did the numbers. 72% of those 20 patients basically stayed sober for 2 years. I was amazed, blown away. For the first time, I felt like in my little doctor bag, I have a tool that actually works against addictions. It's been very difficult to verbalize what exactly we do, but I think the biggest thing that we have is empathy. We treat the people like patients, or we renamed our entire company Family Hospital Systems, because that says what we try to do. We try our best to treat people like we want our family to be treated. If my wife or my son or my dad had an alcohol problem, what would I want the provider to do? What kind of empathy would I want them to show? I would want that provider to be on the top of their game, knowing exactly as much as they can about the addiction process, and be able to give them the most successful recovery that they can. So to make a long story short, I could talk about recovery for 6 or 8 hours. I won't bore you, but it's been a real game changer. That is one of the things that we're involved in that we're very, very proud of. To this day, we've, I think, had about 2,000 or 3,000 people that have come through our facility for medical stabilization. We're having a crawfish boil on Saturday. A lot of them are going to come back and enjoy some crawfish. We also work with postpartum depression patients. We're one of the only, there's a certification you have to be able to give a medication called Zulresso. We've helped a number of women that have postpartum depression. We also work with eating disorders a lot. We do spine surgery, we do orthopedic surgery, general surgery. We of course have the emergency room. We don't do a lot of medical admissions. We're set up to, but we don't, in most of the hospitals, that's taken care of. What we've done a really good job at is trying to help the community with needs that are not being served. So I appreciate your time, and Dr. Rogers, thank you for inviting us to the conference. Thank you.
Thank you. Allison, you're up next.
Let's see if I figure out how to use this thing. All right, so you've heard all night about different things that you can do to access care. Well, if you're an employer, what do? If you're a provider, how do you put all the pieces together for your patients? And we're kind of building this road as we go, but here's where we are. So for just about everybody I know, insurance looks kind of like this. It's this overlapping mess that nobody understands what it is or what to do with it. So my goal, and I know the other advisors in the room, the goal is to create something like this with either the patient or the employer in the center, usually both, with every party being transparent and clear about what they do, how they do it, and what it costs. And when you do that, you can do a couple of things. You can understand what your risk is, because insurance is just contract law and premium is based on risk, right? So what is your risk? Okay, I would argue if you get a flat renewal, you're running at 50 or 60% and go be self-insured right now. If you're getting a 15 or an 18 or a 20, well, we know how to deal with that too, right? Okay, so you understand what your risk is. Eliminate the misaligned incentives. There's a lot of slooshing going on in the different parts of the contracts, particularly pharmacy contracts, and that's the easiest thing to fix, but you need vendor partners who know how to put the pieces together. But you are not going to control the cost of healthcare unless you control the cost of healthcare, which means that you need to reduce the frequency and the severity of large claims. For most of you, for the employers in the room, 20% of your population is driving 80% of your cost, but the really big problem is that 10% of your population is driving 90% of your cost. So if you're not controlling that in some way, then you're never going to get a handle on all of the costs. So figure out what those things are and pair the right solution. I will tell you that direct primary care is almost always part of the solution. Things like family hospital system, we need more of them, just so you know, are a very big part of the solution. There's others, tertiary care, specialists, urgent care that is cash pay without a balance bill. All those things are really important. So once you get all that, what's the benefit for people, right? So we have successfully reduced deductibles, co-insurance, out-of-pocket costs, premium. I had a CEO that got applause. Now he's an introvert and I thought he was gonna die, but he got applause. I mean, when does that happen? It was really kind of cool to watch. So you also need a little bit of support. One of the reasons that plans like this fail, or that patients that don't have good understanding of how their plans work, why they fail, is that people don't know who to talk to. They don't know, well, okay, I got this thing, but what do I do? Who do I call? It's 10 o'clock at night, I'm standing in the emergency room and the doctor is saying this, but I don't really think that's true, but I'm not a doctor. So give people some resources so that they can get those questions answered. I know a lot of very dedicated HR people, they don't want to hear from people at 10 o'clock at night. Just, that's not their job. Provide some resources that can do that. And when you do that, then your benefit plan becomes a recruiting and retention tool. If you're a provider, know the pitfalls, know where people kind of fall through the cracks in the system. Be cautious about where you send people for lab work or bill the lab work yourself. Be careful on where you send them for imaging or bill it yourself. There are a number of facilities that have direct contracts with DPC docs in town. Green imaging is a great thing. I know a lot of you know green imaging. Use those resources to help your patients, even your employer patients. They need help too. They probably need more help than anybody. And find direct contracts or insurers that use those kind of things. So you got to get there, right? You can come in and out of this in any way, and this is a whole lot of insurance kind of stuff, and we're not going to spend a lot of time here, but the faster you go from left to right, right to left, then the more you control your costs. But not only do you control your costs, you control the quality of the care that's delivered. And I stand by that. The biggest predictor of outcome is high quality provider. And if you're doing that, you're doing the right thing for the humans, and I still think that's worth doing. So what does an insurance contract actually mean? So for those providers, I think it's important that you understand how this works. So if you've got somebody that's fully insured, let's say their premium is $1 million, okay? The employer every month is paying out their premium, and they're just paying that money and nobody knows what's happening there. You may have kind of an idea, but you really don't know. When you move into an alternate funding, level funded, self-funding environment, you are creating buckets of cost. So you've got a reinsurance bucket, a stop loss bucket. That's like a deductible on an individual plan. But rather than the $3,000 or $5,000 you're used to seeing, that might be $25 or $50 or $100 or $150,000. And what that means is that the employer is responsible for all covered services up to that deductible. So that's stop loss or reinsurance. And then there's admin costs, a TPA to run a plan. We have one here. Raise your hand. That's Todd Rogers from Kempton. They do some pretty interesting things, by the way. So that's the person that runs your plan, or the group company that runs your plan. They process your claims, they pick up the phone when a member needs help, they verify coverage with providers. Pharmacy benefit manager. You want a transparent pharmacy benefit manager. I like the kind with 7-page contracts, not 40-page contracts. They're much easier to understand. You want to make sure they're working on a warranty that they accept only their administrative fee. So any other plan services, if you've got advocacy or concierge or direct primary care or anything like that, that would be in the administrative bucket. That is what an employer would pay every month, right? So they pay the stop loss and the fixed costs. As they go along, every week, they pay their claims. So some weeks it'll be a couple hundred, or depending on your size, a few $1,000s, and other weeks it will be a little bit bigger. Okay? Now, the way claims work is an underwriter will look at your group and they'll say, we expect to see $800,000 in claims, but we are going to allow ourselves a little bit of wiggle room. So what you'll find is something called an aggregate, or the maximum that an employer needs to pay in claims will be a little bit more than that, 20 or 25%, depending on how you're doing the math. So if you look on this slide, you'll see the claims costs are 10%, 20%, 30, 40, so on, until you get to 100%. When you're moving, or an employer is moving from fully insured to self-insured, there's going to be a sweet spot. That is the green there. When we move people from fully insured to self-insured, we expect that their claims are going to come in this instance, in that $576,000 range. That's what we expect. However, the more things that we can do to control the cost, transparent pharmacy, direct contracts for care, proper auditing of claims, all of those things will reduce the claims cost. So we typically see what's in the green, but it is always possible that they'll end up in the red the first year, or any year actually. But the first year is really the year that makes people nervous. So ideally, you're breaking that out, you're identifying it, and you're preparing an employer for paying so much every month, and then this little bit of a variable cost. Over 7 years, a typical employer will end up with a 2, 3, 4% increase over 7 years, rather than 30, 40, 50, 100. So it's not a strategy to save money right now. It is a strategy to save money over time, significant money over time. I know that's a little bit in the insurance weeds for the providers, so thank you, but I think it's important you kind of know how this works, right? So what does it look like? Well, when you can identify the claims, and this is an employer in San Antonio, and I'm not going to say who the employer is, and I'm not going to say who the BUCA insurance carrier is, but it's somebody we know well. This plan has about 2,500 people on it. When we took a look at their claim run, all their itemized claims from the last year, was $18 million in billed charges. $6 million of it was paid on a DRG code. Okay, so that means that there were a lot of emergency room visits that were probably level 1 visits and got paid at level 5. There were 33 CMP tests that were paid, not billed, paid at $1,860.97 from one hospital system in San Antonio. What does that cost? $2.47? Okay, $1,860. I know it costs more in a hospital. I don't think it costs that much more. Okay, so you can catch all of this kind of stuff and you don't have to pay for it. Drugs. So we use an alternate sourcing company for specialty medications, and they source from either tier 1 countries, so Australia, New Zealand, Canada, or England. You know, we're not talking the Wild West or anything like that. They will typically save 40 to 70% per drug. Nothing here is very strange. 85% savings. Okay, we had a woman who took Demista, mid-level employee, made about $70,000 a year. So not nothing, but not a lot, right? The Demista on her particular PBM over the course of a year was $3,600. She had a $50 a month copay, $50 a month out of her pocket, $3,000 for the employer. We sourced that drug for the year for $732. The employer saved $2,300. The member paid nothing. And at $70,000 a year, $50 means something. Right? So you can do really good things like that. You benefit yourself and you benefit somebody else. J-code redirection, J-code white bagging, huge issue, huge, really hard to solve unless you have vendor partners that will allow you to drop ship to you or don't white bag. Right price for care. This price was negotiated by Acerta. By the way, those of you that know Acerta, this price was negotiated by Acerta. Not the surgeon fee that came from a network, but the facility fee and the anesthesia fee were negotiated by Acerta. So a typical knee replacement in the United States is $57,000. San Antonio is 36, 40. Not right to me. This patient did 2 knees. I think she's crazy. 2 at the same time, and $21,000. And the original price was about $28,000 or $29,000. We said, well, you know, we know it's 2 knees, but they're being done at the same time. They were like, oh, well, we'll just drop this to 21, blah, blah, blah. Oh, okay, it really wasn't difficult. It wasn't challenging. It just was a conversation. The money was at the provider the day the surgery was done. She had the surgery, she was there overnight, she went home, she was very, very grouchy for a while because she does not respond well to opioids, and then she went on her way and she was just fine. So these things are all possible for you if you are directing people that need this kind of care or if you're an employer for your employees. Questions? Alrighty, you got your insurance lesson.
Thank you, Allison.